That's a great question, actually, Claudia. I wonder whether it might be easier for everyone, all the participants, to turn your videos off, simply because that means that we can all manage our bandwidth, especially those that are sharing their video. Just to give you a heads up, also, if you put your questions and comments in the chat, then we'll be visiting the chat kind of throughout the presentations too. Perfect. So welcome everyone. It's such a pleasure to have your attention. My name is Ellen Coughlin. I'm Programme Manager at the Health Foundation, and I'm pleased to be chairing this panel on methods for using and linking routine data. We began planning this session 6 months ago, and since then we've seen high quality analysis of healthcare data really take centre stage in a way that we can never have anticipated. Of course, the NHS sees a colossal amount of data recorded with every passing moment, but much of this is routine data, the primary function of which is to record clinical and operational activities. So analysts are secondary users of the data with limited information about the context in which that data was recorded, which in turn can give rise to the risk of drawing faulty conclusions. A particularly relevant example of this might be the weekend effects that we're seeing in COVID-19 mortality statistics. So I'm pleased to introduce to you 4 speakers who will showcase the approaches that they've used to address some of the difficulties that they've encountered working with this messy, sometimes patchy healthcare data. And we'll hopefully give you some tips on how to get the best insights from the data that you're working with. Please make sure you're muted. We'd encourage you to contribute to the discussion by commenting or posting questions using the chat function. So first up, I've got the pleasure of introducing Laurie Edwards-Fares, Clinical Analyst at Nottinghamshire NHS Foundation Trust and incumbent AFA Analyst of the Year.
Good. Hello, everyone. Let me go to...
Hi.
Hello.
I'm going to be talking to you about building clinician and analyst relationships to improve the quality and understanding of healthcare data. Next slide, please. Next slide, please. So just quickly about me, I work for the Clinical Development Unit as part of Nottinghamshire Healthcare NHS Foundation Trust, and I'm specifically a clinical analyst for the specialty of liaison psychiatry. Next slide. And on the next slide, please. Next slide. So this is the flowchart of data, and most analysts tend to just focus on the data being extracted from the database to making sure that the question that they have been asked has been answered. But actually this journey is much more complicated than that. And with all of this, we need to make sure that we've got the context to the data. And so obviously this data starts with a patient then shares this information with a clinician. And it goes all the way through until the data is used to affect change. Next slide, please. So firstly, we need to think about the clinicians and the admin that are inputting the data. We need to consider their understanding, because actually they may not be understanding the field in the data correctly. And that will very quickly mean that all the information that you've been collecting is very quickly corrupt, because you've got different people doing different things. It's often useful to feed back to them as to why this data is helpful, because most clinicians do the job that they do to aid patients and to help patients. And sometimes data is seen as a bit of a chore and a bit of a bore. So actually, if you can explain why the data is helpful and how by filling that data in, they are assisting not only the patient in front of them, but other patients that are around, you quickly find that they are much more helpful and much more compliant. It's also worth then considering what challenges do they face, which bits seem particularly laborious, which bits are confusing, which bits, can we go back? And then, so we need to consider the challenges that they face, because the more challenges they face, the more likely there is to be issues with this data. And my final thing with this is always make time for that relationship, because a lot of these people will be very, very busy human beings. And the better relationship you've got with them, the better understanding you will have of the data, because you will know the context as to why they're filling in. So this involves just go and say hello. Don't just make every conversation about data. Just go and be friendly with them. Next slide. So these are 3 times where this has been really crucial. So there is a box in our electronic patient record called First Language. And I've got some teams that have adult patients and some teams that have older adult patients. And so the adult patients, we're using this First Language box as primary communication language. So at this point, I like to pick on my mother. She is Spanish, born in Spain, moved to the UK a few decades ago, speaks very good English. And if she was to meet an adult team, most of them would document her as an English speaker because she's got no problems communicating. However, with older adult teams, they tend to use mother tongue. So they would document her as Spanish. Because, especially in mental health, a lot of these patients end up with symptoms of delirium and dementia. Actually, the common symptom of that is to go back to speaking a native tongue. And so for them, it is useful to know what other languages people spoke, especially as children. What this means is that both teams are using this box to their clinical advantage. But if someone was to ask in Nottinghamshire how many patients accessing mental health services cannot speak English, your data is a bit fuzzy because in the older adult teams, there's lots of people that can speak English that will be documented separately. Marital status is similar, especially in mental health. It's quite crucial to know because a change in marital status can be quite a key factor in people's mental health deteriorating. And yet we found that there were some people that were listed as single, who came into service as single, got married, separated and remarried, and that box was never updated. And so a lot of people might go, oh God, where's that clinical data? We need to know that. The answer is the data is there. It is in the progress notes. It is where it needs to be for the clinicians. It's just not translated into a way that helps analysts. And while we would all be very keen to see that data in a very accurate way, it is there clinically, and it's about trying to work out how we can make it work for them and for us. Another one that we looked at is referral reason. This is a non-mandatory field. This field, because it's not mandatory, does mean that it can easily be missed. And so the biggest thing was this was trying to form a habit. And again, that involved talking to the clinicians, finding out what they thought of the list, because the list that initially was not very suited to the team. What did they think of the list? What sort of things were needed? And so I've got one team that the way that they get on, they like to wind each other up. So we would always do a competition, see who had done the worst that week. And they would all place bets as to which person had forgotten the most. And that worked well because none of them wanted to be the one that lost. Whereas in other teams, it worked much better to say these are the ones that have done the best. And again, it's by knowing your teams, you know how to increase that. And now referral reason is a very valuable data source for us. But 9 months ago, it wasn't being filled in because nobody had explained to the clinicians why. Next slide. Next slide, please. So now we need to consider the data requester. So who is it that has asked the question of the analysts? The first thing we need to look at is the consistency. So how often are they going to ask this question? Is it a once-off or is it something that they're going to want monthly, weekly, quarterly? Because if it is something that's needed consistent, then you need to plan it in such a way that they can see it in a consistent format. And we'll discuss data literacy in a minute. Often people ask a question with good intentions, but when they're not familiar with the data that's behind, the question that they ask and the answer that they get for that question may not be what they want. So it's always very important, I've found, to ask why they are asking that question. So if somebody goes, how many contacts has this team had? You can then go, well, why are you asking? And quite often it's they want to measure performance. It's like, well, okay, well then let's consider the fact that number of contacts doesn't tell you how long a contact is. Somebody may have a clinic and they can fit 10 appointments in a day because they're each half an hour, and someone else's clinic may only fit 3. But each of those 3 appointments were 3 hours long. So again, by asking why, you can get much more out of them, and together you can use their clinical knowledge or their knowledge of management to know what they want with your knowledge of the data to piece together a very good story. We then need to consider also the risks of the question being answered badly, that they may just go on to use that data and affect change. And if that data could potentially show, as I said, for example, low contact, because they're doing really long contact, then it can affect things like funding, it can affect things like staffing, and it can affect lots of different things. So it's why by understanding the question and giving a very good answer to the question, it has much more benefit. And it's not that people would answer the question badly intentionally, it's where there is that misunderstanding. And so the next bit we come on to is data illiteracy. Next slide, please. So here are 4 graphs, and I've shown these at quite a few conferences. And I always ask people to take a moment and try and work out, it's all fake data, but how many teams' data is this demonstrating? And when I've been to the other conferences, everyone always sort of says 2 or 3 or 4, but the answer is there is only one team's data in this, which is just number of assessments, number seen on time, number delayed, and percentage seen on time. But they have been presented in 4 very different ways. And so when you've got an analytical mind, you look at this and you can't piece together quickly that these are 4 different teams, but these are not 4 different teams, these are just one team. You can't expect somebody that is less literate to do the same. And when we talk about data illiteracy, it's quite easy as an analyst to forget what it's like to be less data literate. In the same way that most people that are watching this now will not really remember what it's like to not be able to read English, to look at these words on a piece of paper and then mean nothing to you. So, and it's the same with graphs. It's very easy to, as you get more competent with graphs, to forget that not everyone is. And that's where things like consistency and presenting in the same way each month saves everybody time. But it also just gives people a fighting chance because each one looks so different that the wrong conclusions can be drawn. Next slide, please. So, in conclusion, these would be my take-home messages with trying to make sure that you've got the right relationships with clinicians and have the right approach to it. The first one is don't make assumptions, and this mainly comes from the data. If you've got a data field that isn't blindingly obvious, for example, just GP name, there's any ambiguity in it, go back and ask the teams, because if you've got some uncertainties, then they may as well. And again, I've even asked clinicians that have been dead certain and they've come out as unsure. My other one for building relationships is fix a problem. Doesn't have to be a big one, but if you find a way that they're having difficulty with recording data or the computer system's not quite up to scratch and you can just make it that little bit better, I found that this is often the best way to win these people over because they know that you're on their side. And a lot of the times data has been enforced on clinicians rather than being used to benefit them. And so if you can start fixing the problem, then you can get on side. And my final one is be available for people to come to you. There is a lot of, if you just go to them on your time scale and force data on them, most of them are going to tell you to go away again. Whereas I let my clinicians know what days I'm in the office, which days I'm not, where am I going to be based at any one time, and they know to come to me. Thank you very much for listening.
Thank you, Laurie. So much of that resonated with me, especially around that sort of human aspect of how we ask questions and answer questions in a best way and maintain those relationships. And I'm sure it will have resonated with lots of analysts and clinicians in the audience. Again, we'll be taking questions at the end, so please do submit your thoughts, questions, anything else in the chat box, and we'll return to Laurie a bit later on. Next up, we have Hannah Knight, Principal Data Analyst at the Health Foundation, to describe her experience evaluating maternity care using routinely collected data.
Thanks, Ellen. So I'm going to talk about the topic of missing or inconsistent data, and these, for all the analysts in the audience, as you all know, are very common problems when we're using patchy or messy routine data. And the examples I'm going to be using are from the time I spent trying to analyse hospital episode statistics data to evaluate the quality of maternity care. As Ellen said, I'm now based at the Health Foundation, but the work I'm presenting is actually from my PhD, which was at the LSHTM and funded by the RCOG. Next slide, please. Okay, so a little bit of context here. So HES is a database that contains details of all admissions to NHS hospitals. So in theory, it should be a fantastic source of information for maternity care because almost all births take place in NHS hospitals. HES has the ability to record multiple procedures and diagnoses, which would be useful for process and outcome measures. And it also has the ability to capture additional key variables about the birth in what's known as the maternity tale. However, when I started my PhD, the credibility of HES had been challenged in a fairly fundamental way. So you'll see here on the slide, the graph on the left is actually from a letter that was published in VMJ and it appeared to reveal between 15 and 20,000 births a year to male patients. And this obviously generated some quite widespread concern that basic information like the sex of the patient was being entered incorrectly on a large scale. And it did lead to quite considerable distrust of statistics that are based on HES in the clinical community. But on further inspection, it turned out that almost all of these male births were actually related to male newborn babies that were treated by associate specialties. So that explained that, and I think this example highlights how at first glance using raw routine data can lead you to the wrong conclusions if you don't subject it to systematic analysis and quite careful data quality checks. And in this case, taking the data at face value would have led you to probably throw the baby out with the bath water, which is what has happened to this baby on the right here. So I want to talk about how, on the one hand, we can avoid throwing the baby out with the bathwater and make maximum use of routine data, but on the other hand, tailor our approaches to appropriately deal with data that is often messy. And hopefully some of the examples I'll give might provide you with ideas that could be applied to your analysis, even if that's in a different specialty or using a different data set. So next slide, please. I'm going to talk about just two data items that were really important for my analysis, but were also particularly problematic in terms of data quality. So the first is method of delivery. So lots of statistics require this information, either as part of the numerator or the denominator. But the thing in HES is that it can be recorded in multiple different places. One of these places is the procedure codes, the OPCS codes, and there are a set of codes that relate to the different delivery methods. You can see these here in the little table on the right. And the other source, as I mentioned, there's this set of variables known as the maternity tail, which comes from data that's normally entered by midwives, and that's part of clinical practice, and that also ends up in HES. So the fact that there are these two sources and they can be mapped directly to one another does raise questions for analysts. I've listed here, so which one do we trust? Is there a gold standard? Do they agree? When they disagree, can we resolve these disagreements? And does it matter which one I use? So next slide, please. So here, what I've done is cross-tabulate the two different coding frameworks. So you've got the OPCS codes as columns and the delivery method codes from the maternity tail as the rows. When we look at among birds that have both of these variables recorded, it seems like the overall coding agreement is very high. So all the blue diagonal cells add up to 96% of all deliveries. There is agreement. And for cephalic vaginal birds, which is the most, it's the largest category of birds, there's 99% agreement. But it does also appear that the disagreements exist, those are the red cells, and they don't appear to be randomly distributed. So there's quite a lot of disagreement about type of cesarean section, whether it's emergency or whether it's elective, also about which instrument was used. And that can really matter if you're wanting to look at trends or variation in the use of these different interventions. The most problematic category here is also one of the smallest categories of birth, which are the breech births. That's when the baby's facing head up instead of head down into the pelvis. And the coding agreement here is less than 50%. And that's quite a problem because there's a lot of controversy around how breech babies should be delivered, either vaginally or via a cesarean section. If we use the OPCS codes, we get 1,800 or so vaginal breech deliveries a year. If we use the maternity tail, it's almost double this number. And I've not shown it here, but when you examine these inconsistencies at a trust level, we see that there are actually about 12 trusts that account for most of the disagreements here. So one option, which we use in some of our analyses, is to exclude the problematic trusts. And as Laurie said, it's also really important to feed back to those trusts that we found these problems, and we did see some improvement over time as a result of that feedback. Next slide, please. So another option, if you've got disagreements, is to try and resolve discrepancies using an algorithm. And again, as Laurie highlighted, it'd be really important to speak to clinicians here and get their input into the design of any algorithm. But the idea would be that you'd look for clues elsewhere in the same data sets, in this case in HES, that would try and resolve the discrepancies. So I won't go into a lot of detail on this slide, but this is an example based on disagreement where one source says the cesarean was an emergency and the other says it was planned. And we can use ICD-10 codes to look for clues as to whether there was whether this woman laboured or whether she had an indication for a planned cesarean section, to try and resolve some of these disagreements. And in this example, almost 60% of agreements could be resolved using this method. Next slide, please. So the final thing I want to say about method of delivery is that the choice of definition rule that you settle on can and will, in many cases, have a big impact on your resulting statistics. So an example here is the proportion of babies in the breech position that are delivered by elective cesarean section. And we could use the OPCS codes, we could use the DELMETH codes, or we could only use cases where they're both present and they agree with each other. And there's almost a 6 percentage point difference here between two of these definitions, which would be quite significant if you're trying to look at trends over time or compare with the rate with other countries. And that's on a national level, but on a trust level, the average difference between trusts, between using the two of these definitions, was 5.5%, but in some trusts it was as high as 31%. So that's a key message for those who use or publish trust level statistics, that the decision about how to handle inconsistent information really matters, and it's really important to be open about which definitions you're using and why. Okay, so next slide, please. The second example I want to talk about is maternal parity. Next slide, please. In studies of maternity care and looking at outcomes and processes for women and their babies, it's really important to know whether a woman is having her first baby or whether she's already had one or more births. It's one of the strongest influences on the need for intervention in the current pregnancy. However, despite the importance of this information, there are particular concerns about the recording of this variable in HES. So this table here shows less than 60% of trusts had the expected distribution of parity. Over a quarter had less than 70% completeness of this variable, and the rest had implausible distributions of parity. We can talk about why that might be the case later if there's time. But not being able to use this variable or not rely on it really limits the extent to which HES can be used for studies of maternity care. So next slide, please. I want to talk about an approach that we tested to try and derive information about parity using an alternative method, which was to follow an individual patient who's giving birth now back within HES over many years using the HES ID, which is a unique patient identifier assigned in the data set. And we did a sort of validation exercise here, only using trusts that had good quality data in the maternity tail, and that was our gold standard. And then we looked back 9 years within HES and followed those women to see how many births they'd had. And we measured agreement both using sensitivity and specificity. So next slide, please. So this technique here, it was quite good in accurately labelling women as multiparous, and so having had a previous birth or more than one. And it had an overall positive predictive value of 99% for picking up multiparity, but it was less able to correctly label women as primiparous. So the overall negative predictive value of 72%. And that's because this historical look-back approach could miss past pregnancies, either because those pregnancies didn't happen in the NHS, they may have happened overseas, or in private maternity care, or be in HES, but prior to the look-back window of 9 years that we were using. There's also issues around the way that the HES ID algorithm may be affected by changes to patients' demographic data and data errors. And particularly with this population of women of reproductive age, they might change their surname between pregnancies if they've married or divorced or remarried in the intervening period. Postcodes can also change a lot at this time as families move house. And some births might be registered jointly by parents who live at separate addresses, which could affect the accuracy of the postcode. And again, as with the previous example, we can see that on an NHS trust level, there's evidence of trust level difference in the performance of this technique. And in London, it was particularly poor, which could also reflect how often people move house, or perhaps the proportion of people who've had births outside the NHS in London. We also found that it varied among different subgroups of women, so it performed less well among women of non-white ethnicity and for women with the highest social deprivation. And next slide, please. I just have a few take-home messages from this work, sort of trying to present a way of approaching data to, first of all, identify data quality problems. Lots of techniques that you could employ here, comparison with existing literature, looking at plausible distributions, both at the record level and the trust level, and completeness and consistency, as I've talked about. I think a key message here is not just to focus on completeness, try to identify records with implausible or inconsistent data, which will require often clinical input. And don't forget about trust level variation, because we often found that it was a small proportion of trusts that account for the vast majority of these sorts of discrepancies. And then it's about testing the impact of different approaches. As I've highlighted, decisions about how to handle inconsistent information do really matter, and it's important to use sensitivity analysis to test these before you decide on your approach, and that decision will be affected by the type of analysis you want to undertake. And then really importantly, to document your decisions, especially if you're publishing trust level statistics or putting statistics out in the open. People will want to try and replicate your definitions and understand why you've settled on a particular definition rule, and feedback data quality problems to the data owners, because often it's the first time anyone has ever done so and they're not aware, and you can get really good interaction between clinicians and their informatics teams, which we saw many examples of them working together to resolve the types of problems that Laurie talked about in her talk. So thank you very much.
Thank you, Hannah, for highlighting how important those techniques are to identify and improve data quality issues. And we'll return to those thoughts and questions from the audience a little later on. But I'm pleased now to introduce Pia Hardelid, Associate Professor at UCL Great Ormond Street Institute of Child Health, to describe some example of work that she's done to link routine data with other rich data sets to improve insights.
Great, thank you very much for that introduction, and I'm delighted to speak to you this morning. So I'm going to give you an example of how we used linked hospital administrative data from Scotland for a study to improve robustness and validity. So can we have the next slide, please? So the results I'm going to show you in the methodology today, they were published in this study that came out in 2017. And the aim of this study was to look at risk factors for children being admitted to hospital with influenza. So as you know, influenza is another respiratory infection which has the potential to cause pandemics. And it's estimated that every year there are about 90 million new cases of influenza in children globally. And in the UK, the hospital admission rate for children under 2 years old for flu is about 2 in every 1,000 children. So every winter, about 2 in every 1,000 children are admitted to hospital with influenza. And can we have the next slide, please? So to mitigate that impact and reduce the risk of hospital admission, which is particularly high the younger you are among the sort of child's age group. So babies under 1 have the highest influenza admission rates. We have introduced influenza vaccination programs. So, and this is what the program looks like for children at the moment. So if you are over 2 years old, every winter you are offered a live attenuated influenza vaccine, which is in the form of a nasal spray. And for children between 6 months and 2 years, there's a targeted program whereby children with underlying conditions that are thought to increase the risk of severe symptoms of flu, like congenital heart disease, neurological conditions or chronic lung disease, they are offered inactivated influenza vaccine, and that's in the form of an injectable vaccine. And for children under 6 months old, there is no licensed flu vaccine, so those children are meant to be protected through vaccination of pregnant women, but there's some uncertainty about how long those maternally acquired antibodies actually last, or whether they last up to 6 months. And so in this study, we were interested in looking at risk factors for hospital admission in children under 2 years old who are not eligible to receive universal influenza vaccine. And so we wanted to ask sort of how can those children be protected? So can we have the next slide, please? So this is one of the problems when you're using things like hospital episode statistics and other hospital administrative databases to look at specific pathogens. So this is from a few years back. This is the pneumonia diagnoses in HES. This is across all ages. So there's nearly 470,000 Finnish consultant episodes in HES of pneumonia. So it's very, very common. And the bar chart there shows you the proportion according to which type of, according to the type of the ICD-10 code. And the green is the code J18, which is pneumonia organism unspecified. So basically the vast majority of pneumonia episodes in HES, we don't know whether they were caused by bacteria or virus, or for that matter, which virus. Was it flu? Was it a respiratory syncytial virus? And this is a big problem, which we want to know how many children were admitted with flu. So there's been a number of studies, particularly from Western Australia, and they've shown that clinical coding, like the International Classification of Diseases of diagnoses, they have a high specificity. So if there is a specific influenza code used, it's very likely that those children did have flu, but there's very low sensitivity. So if we use clinical coding to identify flu cases, we're going to miss a lot of the admitted children. So can we have the next slide, please? Yeah, sorry, could you go forward with all the animations? I think there's a few more. Great, thanks. So, thanks. So for this study, we tried to overcome that by using linkage to public health surveillance. So in this study, we didn't use HES. We used data from Scotland. So Scotland's got a brilliant data linkage infrastructure for health and even non-health data. So we had a number of linked data sets from around the time of birth, like birth registration, maternity records and Scottish birth records, which has information on birth weight, gestational age, the month of birth, and any sort of diagnoses like congenital heart disease, for example, indicating chronic conditions. So We had a lot of information on important risk factors recorded at around the time of birth. And then to identify influenza admissions, we had hospital records from the Scottish equivalent of HES, which is the Scottish Morbidity Record 01, SMR01. And we linked those to something called ECOS. And ECOS stands for the Electronic Communication of Surveillance in Scotland, and it's held by Public Health Scotland. And ECOS contains information from microbiology laboratories across Scotland, and they report results of positive isolates for a number of bacterial and viral pathogens to Public Health Scotland. And so we had an extract of all positive influenza. Sorry, my son's here, I can't talk right now. All positive influenza results reported to Public Health Scotland via ECOS, and we linked those to the hospital records to get a sort of definition of a influenza-related hospital admission, which is any hospital admission, any unplanned hospital admissions where we had a positive ECOS episode up to 1 week before and up to 1 week after the hospital admission date in SMR01. And children were followed from birth up to 2 years of age, and we followed children. We followed the follow-up period where we looked for outcomes was between September 2009 and May 2015. And all these data sets, they were linked using the CHI number, which is sort of like the equivalent of the NHS number in Scotland. And can we have the next slide, please? So we had a big cohort of 424,000 children. So that's all singleton births in Scotland between October 2007 and April 2015. And among those, we had over 1,000 influenza-related hospital admissions. And if we had used just the clinical coding to identify influenza admissions, we would have estimated that hospital admission rates in children under 6 months old was 30% lower, and in children between 6 months and 2 years, we would have estimated that hospital admission rates for influenza were 50% lower compared to using the linked ECOS records. It would have made quite a big difference, and we would have underestimated the risk of influenza in these young children. And can we please have the next slide now? So sorry, I've got animations. One more, thank you. So I'm just going to show you the results for children under 6 months old in the interests of time. And please have a look at the paper. The results were relatively similar for children between 6 months and 2 years old. So we found that sort of the most important risk factors for influenza-related hospital admissions in this group were whether the child had a high-risk chronic condition, like I said, chronic lung disease, congenital heart disease. When they were born, so if they were young, so under the age of 6 months old, during peak flu season, which tends to be January, February, they were at higher risk. If they had older siblings, so if they had one older sibling, their risk was doubled, and if they had 2 or more older siblings, their risk was tripled compared to children who didn't have any older siblings. And then also maternal age. Can we have the next slide, please? So if we look at the population attributable fraction, so that's the proportion of influenza admissions in children under 6 months old that could have been prevented had all the children had the same risk as children in the lowest risk group. So if all children had the same experienced the same risk of influenza admission as children who didn't have any older siblings, flu admissions in these young babies could have been reduced by nearly half, so 46%. And can we have the next slide, please? And this was picked up by the media, so we had a lot of media attention here. So basically, this really resonated with parents, I think, because if you have more than one child, you know that the youngest one is going to be at higher risk from the older ones when they are snotty. And can we please have the next slide? And we also repeated this methodology to look at admissions for respiratory syncytial virus, which is another very, very common, in fact, more common respiratory infection in children. And then next slide, please. So go back, yeah. So the other thing that we found in this study on flu was that if all children had the same risk of being admitted as children whose mothers were aged in their 30s, then we could have reduced hospital admissions for flu by about 20%. And because we adjusted for parity here, we think that this maternal age effect is actually indicating maternal age at first birth, which is a very, very strong indicator of socioeconomic disadvantage. So basically what this study was showing was that children growing up in poorer families were far more likely to be admitted to hospital with flu than children who are growing up in more wealthy families. And this is quite a well-known phenomenon. Now we can have the next slide, please. So we don't know, however, why children from poorer families are more likely to be admitted to hospital with respiratory infections like flu. We also found the same thing for respiratory syncytial virus. So we've been very lucky to be awarded a grant by the Medical Research Council to look at the role of air pollution and housing in sort of leading to respiratory tract infections in children requiring hospital admission. So we have a study called PICNIC, because and the aim of PICNIC is to look at whether by improving air quality, ambient air quality, and improving housing, we can reduce the risk of being admitted to hospital with respiratory infections like flu and respiratory syncytial virus, and whether these interventions would be able to reduce the social inequality and the social gradient that we see in these admissions. So basically to try and improve the respiratory health of poorer children. Next slide, please. Yeah, there's a few more animations. One more. Thanks. So in this study, we're going to use data from both England and Scotland. It's to create national birth cohorts of all children born in these two countries. So in Scotland, that will be between 1997 and 2019. And in England, it will be babies born between 2005 and 14. And we have a huge number of databases that we're going to link up. So on the top there, we have the SPINE, which is going to be birth registration data linked to maternity records and birth notification data. And we're going to link that to hospital episode statistics and SMRO1 for both mothers and babies in Scotland. We have a linkage to vaccination data as well, and death registration data to be able to calculate person time at risk. And then we're going to link those data sets to small area level data on ambient air pollution and distance to major roads, to tobacco expenditure data, because in England we don't have individual level data on whether the mother was smoking during pregnancy. And they're going to be linked via the Population Demographic Service and the CHI database in England and Scotland respectively, so we can get longitudinal exposure data, and that'll be linked up to the health data and the birth registration data. And so in the end, we'll end up with a cohort of about 8 million children born in England and Scotland in those years. We're also linking to, we're also creating a validation cohort where we're linking these birth cohorts to 2011 census data to be able to get very, very detailed information on socioeconomic status, which is going to be a major confounder here. And then we're also linking to some very fine air pollution data as a validation, which we only have for Glasgow and London. And that's, in the interest of time, all I'm going to say. But can we have the last slide, please? Can we have the last slide, please? So in terms of summing up, we know that coding in hospital administrative sorry, can we go up again? Sorry, yeah, so we know that hospital administrative data lacks sensitivity, and we can, in terms of the clinical coding, so that can be overcome using data linkage. And as I've shown, the linkage to maternity records, laboratory, public health laboratory data and environmental data allow these very big birth cohort studies to be established at very minimal cost, and they're non-invasive for participants. However, there are long lead times for setting up these linkages. So in England, it's taken 2.5 years to set up the data for the PICNIC study, and we're still in 6 ethics committees. And in Scotland, it would only require 2 ethics committees. So I think there is definitely scope for reducing the time and money spent on acquiring approvals to link these data sets. And that's all I wanted to say. So now can we have the last slide, please? So I have a number of colleagues to thank. The flu study was sponsored by NIHR, and PICNIC is sponsored by MRC, and I work with a number of very talented people to do this research. So thank you very much.
Thank you, Pia, for showcasing just how powerful linked data can be. At the Health Foundation, we've just set up the Network Data Lab to explore linking data, and I'm sure that a lot of the audience will really understand those difficulties and the length of time it takes to safely link different data sets. And so to everyone, I'd urge you to follow up on Pia's work and the PICNIC study to find out more, but of course you can post questions and thoughts at the bottom as well. So finally, I'm pleased to introduce you to David Cromwell, Professor of Health Services Research at London School of Hygiene and Tropical Medicine, and the Director of the Clinical Effectiveness Unit at the Royal College of Surgeons.
Hello, everybody. I'm going to give a quick introduction to how to evaluate long-term outcomes this morning using routine health data. And I'm going to use 2 examples related to surgery from that. Next slide, please. You're probably aware that the reason why many hospital databases can be used for this type of work is that they include a unique patient identifier that can kind of support these long-term outcomes. So if you've got a cohort study you're planning to look at and you want to see long-term consequences of surgery, these databases now, for example, Hospital Episode Statistics covers well over 10 years, can be used to generate quite a detailed description of a care pathway that people follow, as long as, of course, if you know their date of death, so you know when they leave the data set. There's been some quite interesting work in this area in surgery. I've listed 3 examples at the bottom of this particular slide, but there are many others. Next slide, please. So the first example I want to talk about today is from vascular surgery and relates to people who suffer from peripheral arterial disease, which essentially can limit blood flow to people's feet. And that can cause kind of mild symptoms like rest pain, but also more serious problems like foot ulcers and gangrene, which can lead to lower limb amputation in the most severe cases. And there's various types of procedures that can improve blood flow, including angioplasty or the insertion of a stent. But it can require open surgery like a bypass, where a vein is moved to bypass the blockage in an artery. A common measure of success is what's called an amputation-free survival. And if HES, for example, is linked to ONS, that's easy to then mention date of death. But we're also fortunate enough to have very clear OPCS codes to identify amputations, in this particular case, either above or below the knee. Next slide, please. Now, what I want to highlight in this particular example is the challenge of some of the analytical challenges of doing this type of work. Amputation-free survival is a composite outcome, and that kind of generates problems of interpretation because you're combining the risk of death with the risk of amputation, and most patients would want to know those 2 things separately, valuing staying alive more than potentially keeping a leg. Now, a common way to kind of analyze this data is to use survival analysis techniques and produce Kaplan-Meier estimates of survival. Now, the problem is if you treat one of these events as censoring, it could lead to an overestimate of the particular risk. And that's because the risks are not independent. People, for example, who have died are no longer at risk of amputation. And this can be illustrated, or I've illustrated this with these slides from a study that was published in the European Heart Journal. And if we just focus on the red lines, that's for the people with the most severe disease. You can see that the risk of amputation is 60% at 4 years, but so is the risk of death, which gives you a total risk of 120%, which we all know is not feasible. In fact, the actual risk of amputation or death was quoted at about 80%. But this is a kind of extreme example of the type of problems that can occur. Next slide, please. The way to overcome this is to use these techniques called competing risk analysis. And a colleague of mine, Katrina Hakia, did this using HES data to look at the risk of amputation and death. It was possible, unfortunately, not to recreate the clinical classification of peripheral arterial disease, which is either the Rutherford scale or the Fontoon scale. But the key things to differentiate are between those who have intermittent claudication, or what's called severe limb ischemia, or tissue loss. You can see that it's the tissue loss on the left-hand graph where the risk of amputation is the greatest, up to about 25% after 5 years, although that is actually much less than the reported risk that had been previously published in the journals because of the use of standard survival analysis. Next slide, please. My next example I'm going to talk quickly about is from breast cancer. And an important issue there is that the loss of a breast from mastectomy can have a very large negative impact on a woman's well-being. Fortunately, there are now some various treatment options that allow women to retain a breast at the end of treatment, including breast-conserving surgery or 2 types of breast reconstruction. But these are not always successful, and can also lead for a woman to not have a breast at the end of treatment. So next slide, please. So when we're trying to evaluate the performance of breast cancer services, there's a view that it makes sense to look at a complete care pathway and avoid some of the indicators that are currently being used, such as the mastectomy rate or the breast conserving surgery rate, because they really only provide you with a snapshot of what happened at one part of the care pathway. Now, Joe Meny, a colleague of mine, tackled this problem and proposed a new indicator which looked at the proportion of women who have a breast 4 years after the date of initial breast surgery. And this was possible because the codes for breast conserving surgery or mastectomy and reconstruction are well captured in the OPCS codes used by HES. Next slide, please. Joe described this kind of pathway in this graph, and I'm just going to focus on one particular group, the women who are less than 70 with no comorbidities. It's on the left side. And you can see that there is just over 70% of women who have breast conserving surgery. But because that doesn't always, that can leave positive margins and women go on to have mastectomy, you can see that actually the rate of women who've had that decreases over time. But you can also see an increase in the number of women having delayed reconstruction, which is the green. So this particular indicator allowed us to capture this kind of richness of how whether a woman had retained a breast over time until the end of her treatment. And you can also see that the pathways are very different across the 4 groups. So women over 70, very few of them were having breast reconstruction. Next slide, please. So these are 2 examples of the type of things that are possible, although there are always challenges. Here are some on this slide, which you're probably aware of. Perhaps the lowest, the bottom one at the bottom is the hardest, where in fact, if you're trying to capture care pathways, it can be challenging when in fact there's a medical therapy that's just as effective as surgery, which of course HES is not so good at. So final slide, please. So HES and other databases that capture a use a HES ID to allow you to track patients allows this type of long-term follow-ups, and as long as they are analysed well, can give you a much richer description of what's going on. Thank you.
Thank you so much, David. That brings us to the end of our presentations, and I'm sure you'll agree that that was a really marvellous showcase of how routine data can be used to produce excellent insights. You know, all the way from understanding the questions that need to be asked, to understanding the data quality, enhancing it through data linkage, and then understanding the potential for, you know, wider application of routine data through long-term follow-ups. We're almost at the end of the hour, but participants are more than welcome to stay and listen to the discussion. We have a couple of questions from the audience, and this one is for Hannah. Hannah, has moving to the maternity services data set improved the data of the quality now? Obviously, you had done your studies in the past.
That's a good question. So I have to admit, it's been a couple of years now since I've worked with maternity data, but I did used to work on the National Maternity and Perinatal Audit, which was considering switching over to the maternity services data set as the primary source of data going forward. And I think that that switch over has had to be slightly delayed because, as with any new data set, it can take some time for the level of maturity to reach a level that would be suitable for a national clinical audit. I think many trusts are submitting really good quality data, but because it's a major change of in process, I think it's taking quite some time. But going forward, it offers many advantages because it links the mother and the baby, and yeah, hopefully should overcome some of the problems we have with the HES maternity tail. But unfortunately, so the HES maternity tail was improving in completeness over the sort of 2010s, but in the last few years I gather it's got worse again, perhaps because trusts are struggling to juggle with sort of continuing to submit to HES whilst also having to duplicate effort with the new maternity service data set. So that's a bit unfortunate, but thanks for the question.
And I'm thinking as well, possibly along a similar theme. David, have you considered using cancer registry data to get a clearer picture of what happens to breast cancer patients apart from surgery?
Yes, definitely. And I would encourage people to kind of look at the Office for Data Release website run by Public Health England, because you can access quite detailed cancer registration data sets. It just happened for that particular work that Joe was doing that we only had access to HES at the time.
Thank you. And I wonder, could we come over to Pia now? How much of a challenge, Pia, will linking the data for PICNIC be? Thinking about timelines for getting the relevant approvals, and how can you evaluate the quality of that linkage for PICNIC?
Yeah, so linking all of those data sets, as you can imagine, is going to be a big challenge, but an exciting one. So for England, we have pretty much all the approvals now. It's just a question of NHS Digital linking the data. For Scotland, we are applying for those approvals at the moment. We anticipate that's going to take less time than it has been in England, done in England. So we hope that we are there pretty much with the approvals, but that's taken a long time. I mean, that's taken taken 3 years. Obviously, we started before the project started, the funding for the project started. So it depends a little bit on which data sets are going to be linked in terms of quality of linkage and how many records we're expecting to link. So, for example, the health data sets, we expect good linkage because since in England since 2005 and in Scotland going back many years, we have NHS numbers, or in Scotland KI numbers, that uniquely identify people coming in contact with health services. And so we expect that linkage to be pretty good, and it's been evaluated in a number of studies now. For example,
I think we may have lost Pia, but I wonder, perhaps she will reappear in a moment, such are the perils of doing these things online. I actually wanted to ask Laurie a question. It's so difficult, I suppose, to really understand how impactful that better relationship between analysts and clinicians are to actually improve the way that interpretations are kind of communicated between teams. Is there a way that you think that, you know, on a national or kind of a broader scale, that we can start to address that?
It's harder on a national level because each team is so unique, and I think some of it is appreciating that each team will have its own understanding with it. I think definitely on more of a trust level, it's about just knowing there's lots of meetings that go on and business meetings that happen just once a month, once every other month, that having some of the data present could be invaluable. So I'm fortunate I get to spend a lot of my time with the clinicians and getting to know them. But even if you don't have that dedicated time all the time, because I'm fortunate I'm situated with the clinicians, there are key meetings that go on that do incorporate everyone. And I think it's not just assuming always that managers will know, because information that I've been fed by managers does not always match the frontline staff. And so I think it's just, if you can attend key meetings within a trust and get trust to sort it, then it will feed up better to the national teams. But I don't think it's something you can sort from the top down. It's something that you need to go in right. And it's that you almost only need to address at the very start level, if that makes sense. So the frontline clinicians that are inputting it, and you will see the ramifications all the way through. And it doesn't take long. It's not something that, it's useful to be there all the time, but it's not something that you have to dedicate hours and hours to. These little corridor conversations can be the best thing.
Yeah, and you know what, I think that's so true, isn't it? I've been having discussions with different teams since everyone's been working more remotely, and I think we were discussing that issue of the fact that you can't sit next to someone and learn from them almost by osmosis now. So we are over time, but thank you to everyone that's dialed in and listened, and I thank you in advance to the people that will be listening to this when all of these presentations are shared for the wider HSR UK event in July. So thank you, everyone. Hopefully see you all soon when you all dial in again. Thank you for your time.
Thanks, Ellen.
Thank you.